Hello and welcome to the next talk, Good Pain Management and Errors. My name is Esther Pogatzki-Zahn. I'm a pain specialist and anesthesiologist at the University Clinic Münster, Germany. Here's my conflicts of interest declaration. Pain after surgery is still undermanaged, as shown by many investigations, and almost all studies show around 30% of patients have severe and extreme pain after surgery. Interestingly, this did not change during the last 20 years. More recent data show that pain intensity ratings after surgery depend on the type of the surgical procedure. Here, an analysis of pain registry data, more than 50,000 data sets have been analyzed. And as shown here, with the 10 most painful surgical procedures, many of them are orthopedic surgical procedures. One is a general surgery, proctocolectomy, and some others, indicating that the type of surgical procedure is specific to postoperative pain. And this as well relates to the development of chronic post-surgical pain. Some surgical procedures have higher risk than others for the development of chronic post-surgical pain. So the procedure is important when trying to develop pain management protocols. And the Enhanced Recovery After Surgery Society has, during the last years, developed programs, including pain management recommendations for certain types of surgical procedures. The goal is faster recovery, fewer complications of the patients may live longer, and the cost of care is reduced. They do it for the preoperative, the intraoperative, and the postoperative period, and it's evidence-based, multi-professional, and interdisciplinary. As shown here, and you don't need to read that, it just emphasizes that the Errors Society has recommended for many surgical procedures recommendations, and I would like to pick just one here to give you an example how this is developed. I would like to emphasize how this can be used, and I would like to discuss with you some limitations. So here is the example, colorectal surgery, and this figure points out the recommendations and the algorithm to choose some of the recommended anesthesia techniques, as well as pharmacons to improve pain management and enhance recovery. The blue ones are IV oral analgesics. The purple ones are local anesthetic and regional anesthesia techniques, and the light blue ones are additional adjuvants. And as recommended and said here, you should pick at least one from each of these three categories. And just to pick some, these are NSAIDs, acetaminophen, or gabapentinoids. This is the first category. The second, as I said, is regional anesthesia, and first choice is continuous thoracic epidural analgesia. If this is not possible, wound catheters or tub blocks are recommended. And just if this is not possible, lidocaine infusion is can be chosen. And the third category is dexamethasone, ketamine, bolus, and infusion, and tramadol. So nice choices. What to pick now? This is a good question, and I would like to give you here from another initiative some ideas what specifically can be used out of these choices. This is a prospect initiative, and you can find it here. It's under the umbrella of the ESWA Society, and these are anesthesiologists and surgeons developing procedure-specific postoperative pain management strategies. Again, evidence-based, and for colorectal surgery, they did a recommendation. This is how it looks like at the internet site, and you can for free then check the recommendations they did. And it's available in different languages. I show you here the post-operative interventions that are recommended by prospect for exactly the same surgical procedure. And you can see this is quite similar to what ours is recommending. Systemic analgesics, epidural analgesia, if this does not work, tub blocks or wound infiltration, and multimodal rehabilitation protocols. However, what you don't find here are gabapentinoids and ketamine, for example. Why is that? Prospect is recommending multimodal analgesics on the base of non-opioid analgesics, which are considered evidence-based as the basic analgesics for each procedure. So if you choose one more analgesic, for example, if epidural analgesia is not possible, like IV lidocaine, prospect assesses evidence-based if the additional analgesic intervention, like IV lidocaine here, improves pain relief further in combination compared to just non-opioid analgesics on its own. So a combination, and this is clinically, of course, relevant, needs to be more effective than just one analgesic. For gabapentinoids, it's the same. So gabapentinoids need to be better in combination with non-opioid analgesics than non-opioid analgesics as well. For both IV lidocaine and gabapentinoids, in fact, there are two meta-analyses out. One is a Cochrane database analysis for IV lidocaine, and one other recent publication is for gabapentinoids. And of course, this huge analysis, which are not procedure specific, give more information, for example, about side effects and adverse events. And for both drugs, the balance between efficacy and side effects seem to be critical to emphasize one or the other as first choice analgesic in combination with non-opioid analgesics. This means that IV lidocaine should be only chosen if no regional anesthesia technique has been is possible for the patients, and in fact gabapentinoids are not recommended based on not enough evidence for procedure specific efficacy and based on the side effects shown in other like here the meta-analysis. This makes it more easy to choose from the our society recommended drugs and procedures the best proven evidence-based combinations for this procedure here. Ours as well is choosing the optimal analgesia based on efficacy, and important, as shown here, not just on pain intensity ratings at rest, pain at rest or pain at movement. They are trying to recommend on other aspects related to patients' comfort and balancing it with side effects. As I said, gabapentinoids are from our society, not always recommended because they have side effects. So this is very important to consider if choosing one or the other drug in an analgesic multimodal balanced analgesic recommendation. Interesting is that all these outcome parameters I just showed are not always considered in clinical trials assessing efficacy of analgesic drugs. We tried or assessed outcome domains in clinical trials here as an example in total knee arthroplasty trials, and we did that for other procedures as well. What we were able to show here that only half of the studies, in fact, assessed physical function. That is very important to mobilize a patient in total knee arthroplasty pain efficacy studies. Pain intensity is in almost all studies assessed. Opioid requirements is assessed very often, but fewer studies assessed adverse events and even less physical function. Psychological aspects, only around 10% of the studies assessed these aspects, and so on. So what we think here, we and others, and this is quite a very popular topic in the pain field and in other fields as well, is that we need to decide on outcome parameters that are relevant for the clinic and that need to be assessed in clinical trials for techniques and other aspects reducing pain after surgery. For total knee surgery, this in fact is important because mobilization is very important. And as here recommended by the Alice Society, nerve blocks, for example, are not recommended based on their increased risk of falls. However, this is based on just one study, at least one study that is here cited. And this is a very old study. This is an observational study, and we need more studies on this outcome to evidence-based recommend or not recommend, for example, peripheral nerve blocks for knee surgery. I would say at the moment, we cannot really state if peripheral nerve blocks produce these adverse events or not, at least not based on evidence, because not many studies are assessing. And what we did here in this IMI Pain Care project was to consent with a huge number of experts like anesthesiologists, surgeons, physiotherapists, pain nurses, and patient representatives on the most important outcome domains that should be assessed in analgesic trials perioperatively. And physical function, in fact, was the most important for all panel members voted with 100% in. Others were voted in as well, like pain intensity during activity, adverse events, pain intensity at rest, and even self-efficacy, a psychological aspect. So in conclusion, pain management needs to be evidence-based. We all agree on that, I would say. Pain management needs to be procedure-specific, but outcome is important, and not only pain scores should be used as outcome parameters to decide on what is a good and effective pain management procedure. Side effects are important, physical function is important, and other aspects as well. The examples show that regional anesthesia techniques are still important in the perioperative field. Multimodal analgesia is important as well. Non-opioid analgesics are the cornerstone and the basic analgesics. Other carefully considered multimodal analgesic components should be based on evidence and they should be beneficial in addition to non-opioid analgesics if added. Enhanced recovery means early mobilization, and this can only be based on adequate pain management without side effects, and we need to develop these for certain surgical procedures. I have not talking about long-term outcome here, like chronic pain or even long-term opiate intake after surgery. Maybe the next talk will shed light on this issue. I would like to thank you all for your attention, and I would welcome questions in the question and answer section, or you can send it to me via email. Thank you very much.